All right, review slides 2 through 11 on your own, and we were going to start on page 71. All right, here are some interesting statistics. More than 25 infectious organisms can be transmitted sexually, and they cause dozens of clinical syndromes. STIs are the most common health problem in the United States, with 19 million people per year infected. We're going to talk about the maternal side of this. Chapter 25 will go back farther into the neonatal side of this. We want to look at primary prevention. It's the most effective way to reduce adverse consequences for women due to STIs. Review the box 4.2 on page 71 for classifications, and we're going to start on the next slide. All right, the key to prevention is to prevent or treat as promptly as possible to prevent spread. We'll look at the prevention 5 P's on box 4.3 on page 72. With condoms, what I really want you to remember that we don't use the spermicide nonoxynol 9 with condoms. They can cause ulcerations and actually increase the risk for HIV. So there's some contraindications for some of these use. We want to make sure with condoms they're not expired. The teenager hasn't carried them around in his pocket for 10 years. Women need to even keep those handy. Vaccinations, we now vaccinate for Hep B, HPV, men and boys and girls 9 to 26 can get that vaccination. All right, let's look at specific infections. And this, if you have had micro, this is going to be some review. Chlamydia is bacterial. The most frequently reported STI in the United States. It's very silent but very highly destructive. It is difficult to diagnose in women. Usually 25-year-olds are more likely to experience this. Over 30 has a lower rate. The causative organism is Chlamydia trachomatis, and it is sexually contracted, and babies can get it at birth, going through the birth canal. Maternal effects may be asymptomatic, may have PID, pelvic inflammatory disease, salpingitis, and this may lead to infertility or ectopic pregnancy. The type of discharge is mucopurulent with bleeding. Inflammation and cervical erosion can increase the risk of acquiring HIV as well. The newborn can be exposed to an infected cervix as it is born, and it can cause stillbirth or neonatal death. Another thing that's very common for babies, and that's the reason we give the ointment, the eye ointment, the iloticin in their eyes after they're born, and it's ophthalmia neonatorum. It can affect their vision. They can have pneumonia as well. Screening is going to include culture, DNA probe. We want to do this early in pregnancy at the first visit and repeat if necessary if they're high risk. Management, doxycycline 100 milligrams PO BID times 7 days if they're not pregnant. It's teratogenic, and it also causes dental stains. We don't give this to a pregnant mom. They would take the azithromycin 1 gram PO single dose. That'd be better anyway. How many of you actually take your medications for 7 to 10 days? Not many of us. Again, erythromycin of some sort for the newborn after it's born. We want to treat mom and the partner, take all medications. They had no symptoms anyway, so you just have to take all the medicine until your treatment's done. Gonorrhea, causative organism, is bacterial. It is the oldest communicable disease in the United States. 820,000 people annually contract this. It's a gram-negative diplococci. Direct contact with lesions, genital, oral, anal, almost exclusively sexually acquired. Age is an important risk factor. Teens and young adults with multiple partners. If you're younger than 20, we need to identify the risks and make a plan. May be asymptomatic, may acquire this in the vaginal area or the rectal area due to intercourse, and it can spread from whichever area it has infected. Some of the things you're going to see: abdominal or back pain. We can have premature rupture of membranes, preterm labor, chorioamnionitis, menstrual irregularities, dysuria. Postpartum, we can have sepsis. The type of discharge is heavy green, yellow, purulent. The fetus can have sepsis or IUGR, which stands for intrauterine growth restriction. There can be premature rupture of membranes, preterm birth. Another reason we give the iloticin, because they can cause ophthalmia neonatorum, just like with the chlamydia, it can cause blindness, and there are a lot of times they're co-infected with both gonorrhea and chlamydia, so we will treat for syphilis, chlamydia, and gonorrhea all at the same time. We want to screen at the first prenatal visit and again at 36 weeks for high risk. Treatment: there are drug-resistant strains increasing. Ceftriaxone, do y'all know what that is? Rocephin, 125 milligrams IM once, or 250 times 1. It's going to be age-related. Look at page 74. I'm just giving you, you don't have to know these doses, just know kind of that this is bacterial, it is communicable, just some brief information about them. You don't have to memorize all this. Other notes: again, erythromycin for the newborn, ophthalmic. Treat all partners within 30 days of contact, and we want to teach prevention. There's a legal tip on page 77. Someone at your facility is in charge of reporting these STIs to the health department, and gonorrhea is reportable. When they get that culture back, it's an automatic report. All right, syphilis. Causative agent is bacterial. Treponema pallidum is a spirochete. Mode of transmission: sexual contact, kissing, biting. It can occur transplacentally at any time during pregnancy, depending on the quantity of these spirochetes in the maternal bloodstream. Microscopic abrasions in the subcutaneous tissue can actually help that be able to get through to the bloodstream. Maternal effects: primary stage, a chancre from 5 to 90 days after transmission turns into painless papules and shallow ulcers. Secondary, 6 weeks to 6 months, symmetric maculopapular rash on the palms and soles of the feet and the hands. There's lymphadenopathy. They can have headache, malaise, and at this point the condylomata or warts appear on the vulva, perineum, or anus. If this is left untreated, we go to the latent phase up to 4 years. And if this continues to be untreated, it can go tertiary, which involves the bone, cardiac, and neurological systems. Screening: with any STI or with HIV, we screen for syphilis as well. All pregnant women at the first visit, we do a microscopic exam of the tissue. Serology in the latent stage of VDRL or an RPR, rapid plasma reagent. If untreated, a baby can be born with congenital syphilis. Treatment consists of very simple antibiotics: penicillin G, 2.4 million units IM. If pregnant, remember we can't take doxycycline or tetracycline. Those are contraindicated. Treat all partners, teach prevention. We need to abstain from intercourse until treatment is complete and the evidence that the disease is gone. On page 76, look at that nursing alert for the Jerash-Hexamer reaction. Usually with treatment, if this happens, it's going to happen within 24 hours. Just malaise, fever, and headache. If it's a pregnant woman, she may have to be treated in the hospital. All right, PID, pelvic inflammatory disease. The most common bacteria that are responsible for this is the gonorrhea or the trichomonas. Those are the most common. Let's see. Most commonly involves the uterine tubes and the uterus. The times that this happens more likely to happen is after some incident such as a miscarriage or an abortion, but it can also happen after menses because that cervical os has opened and the bacteria has a way to get in there and set up house. With this, you're at increased risk for ectopic pregnancies 7-fold if you have PID, infertility, chronic pelvic pain, and symptoms can depend on the type of infection. With this, it's not really a test that you run and go, oh yes, we're positive for PID. We do the STI screenings and we're like, okay, they've got a couple of organisms in there. We got some gonorrhea, we got some trichomonas, so let's do a history. Well, we have lower abdominal tenderness, we have cervical motion tenderness. So when we examine and the care provider moves that cervix and just touches it, that motion causes pain and tenderness. You're going to see possibly a temp over 100.5. So prevention, barrier methods, routine screening, bed rest for comfort. It can cause infertility, so we want to give antibiotics. It may be oral, may be parenteral. Again, it's going to depend on the causative agent. HPV, human papillovirus, more than 100 different types. Some of these can cause cancer. They're from sexual contact and can be passed to the newborn during birth. Maternal effects, also one of the things that you're going to see is called condyloma acuminata. These are cauliflower-like masses that are warts that can obstruct the birth canal. They can become so big and affect being able to urinate or defecate or even mobility or the fetal descent. They may or may not need a C-section. Screened by exam and history. There is not a cure. Prevention is the key. Vaccines are available now for women and girls 9 to 26, but they need to have this before they become sexually active. They're at increased risk for cervical cancer. The newborn can have respiratory and or laryngeal papillomatis. These are lifelong issues for these children as well as the parent because they would have to have these surgically removed, either cryotherapy or some surgical technique to remove these warts. We actually had a teen at the health department that was having some removed. He got a little anxious and went and started cutting them off himself on his inner thighs and cut too deep, and just it was a mess. All right, herpes simplex virus. There are the non-sexually and the sexually transmitted. The HSV1 is non-sexual, HSV2 is sexual. Stop. Shh. So this can be transmitted transplacentally. If we have an oral lesion, we don't want to kiss the newborn, and we know stress can cause recurrence of these lesions. It can increase the chance for miscarriage. There's a risk of transmission when there's active lesions and within 4 hours of rupture of membranes. So if there are no active lesions, mom can deliver vaginally. This can cause scarring, IUGR, mental retardation, microcephaly, very high mortality rate for newborns. 86 to 90% acquire at birth. Here are some more signs and symptoms of HSV. If membranes are ruptured, We need to do a C-section within 4 hours if there are lesions present. All right, viral hepatitis. Let's look at hepatitis A on page 80. We know how that spread. Flu-like symptoms, upper right quadrant pain. Serological testing confirms IgM antibody and an acute infection. My dog is driving me crazy. Treatment is supportive. This does not usually cause any kind of chronic liver disease, though. All right, hepatitis B. This is probably the most threatening to the fetus and neonate. We know it's spread by blood and body fluids. Nurses are very high at risk. That's why we have the series before we come into nursing. And then people that use needles and sexually transmitted as well. No specific treatment, just supportive, resolves 3 to 16 weeks. We want to avoid meds that have to be metabolized by the liver, and we want to avoid alcohol during this time. Vaccination is okay during pregnancy. With these guys, we want to bath that baby ASAP to remove those maternal fluids and before we vaccinate them and give them injections and such. Treat infant with hepatitis B immune globulin after birth within 12 hours. It's okay to breastfeed if they've begun the series. These guys usually recover spontaneously between 3 to 16 weeks. All right, hepatitis C. This is the most common bloodborne infection in the United States. The risk factor for pregnant women of injecting illegal drugs, STIs. There is a vaccine now if you haven't had previous treatment. It is okay to breastfeed. And it's decreased by about 40% in the past 10 years. HIV, human immunodeficiency virus. There's estimated 340,000 new HIV infections per year in women. African American women are 50% of these stats, followed by Caucasian women at 17% and Hispanic women at 14%. Majority of pediatric AIDS cases are from maternal fetal transmission. 70% decrease in this transmission since 1994 with the use of antiviral medications and C-section births. This can be transmitted transplacentally though, and as early as the first trimester, but up to 80% is thought to occur at birth. It can be transmitted by breastfeeding. This is one absolute contraindication to breastfeeding. You will not breastfeed the baby if you're HIV positive. Seroconversion to HIV occurs within 6 to 12 weeks. FDA has approved a more rapid testing for this. All right, we want a vaginal birth within 4 hours of rupture of membrane. If the viral load is high, we want a C-section, absolutely no breastfeeding. We want to presume that all newborns are positive for HIV because we want to use standard precautions on everybody. You have to protect yourself. Protect the infant from further exposure. We want early bathing. We want to cleanse the area before invasive procedures. And another thing that we would not do, absolutely contraindicated, is do internal fetal monitoring of the baby if this HIV positive mom is in labor. We don't want to put the corkscrew thing in and possibly inoculate that baby that way. The infant who tests HIV positive at birth may not be HIV positive. These antibodies cross the placenta, so we would need to retest them at 48 hours, 1 to 2 months, and again at 3 to 6 months. We have to remember that transmission can occur at any time. All right, relatively new, the Zika virus, spread through mosquito bites initially, but now it has evolved and it is considered a sexually transmitted disease, and it's very detrimental to the newborn. They're born with microcephaly, their brain doesn't develop, and they have different areas that you avoid, but using condoms is about the only way that can really be prevented. If it's the mosquito bite, then you use off. All right, vaginitis, you can read through that on your own. Right, Trichomonas is causative organism is a protozoa, one-celled flagellates. Most common vaginal infection and cause for discharge. Mom may be asymptomatic. There may be irritation. The cervix and vaginal walls have strawberry spots, petechiae, and painful urination, dysuria, dyspareunia, painful sexual intercourse. We're going to do a wet prep. We have to treat the partner. There's going to be a yellow-green, frothy, malodorous discharge. The newborn can have fever and be irritable. We want to give metronidazole 2 grams PO times 1. Group B strep. The causative agent is bacterial. It is normal flora in a non-pregnant woman. It's contracted through the birth canal during delivery. The mode of transmission is the normal vaginal flora. The risk factors for mom is sexually active, less than 21 IUDs, African American descent, and low parity. Risk factors for the newborn. It puts that baby at higher risk for low birth weight, being preterm, which would be less than 37 weeks. Rupture of membranes over 18 hours, premature rupture, that's considered premature rupture of membranes. Maternal fever over 100.4 in labor. Previous group B strep baby, multiple gestations. We want to screen at 35 to 37 weeks. Maternal effects, more risk for preterm birth, premature rupture of membranes, chorioamnionitis, postpartum sepsis, UTIs. The baby can also have sepsis, meningitis, respiratory distress syndrome. Treatment, ampicillin, IV piggyback 2 grams, loading dose then 1 gram every 4 hours while in labor. All right, stay with me here. We're almost done. Infection control. Y'all can look at that. You know what standard precautions are, box 4.6 on page 87. We used to call it universal precautions. Whatever you call it, just do it. Wash your hands, hand hygiene, all that. The one thing that's not on this slide that we're going to talk about in chapter 25, I just need you to, there's a word I want you to know, torch. T-O-R-C-H. All right, toxoplasmosis, other, which would be West Nile, HIV, chickenpox, which is varicella zoster. I had chickenpox with my second pregnancy. It was miserable. We'll be talking about that. Rubella, that's your R. Cytomegalovirus, and herpes simplex. These we're going to talk about in chapter 25 because they're very high risk to the newborn. As far as rubella, when we vaccinate them, we don't want them to get pregnant for 3 months after that vaccine. We're going to talk about that a little bit later. Cytomegalovirus, respiratory or sexually transmitted, can be reactivated in subsequent pregnancies and can cause fetal death. We talked about herpes and all that. So that's just what I wanted, that word I want you to be exposed to before we get to chapter 25. All right. I am going to, because chapter 5 is super, super short, I'm going to tell you what I want you to know about chapter 5. There's a video that I've posted I want you to watch on female infertility. I want you to be thinking about what are the causes. Why is there more infertility now? Think about how women are getting their careers and they're deciding to have babies later. By the time you get to 30, you get to 35, it just gets more difficult. Look at page 97. Maybe there's developmental anomalies. Maybe there's medications. Maybe they don't ovulate. Also, male infertility, congenital disorders, chronic illness, nutritional deficiencies, obesity is a big one. STDs, STIs, that's what they're called now. Let's see. I want you to go to page 100. Top right hand on the second paragraph. It says that herbal remedies do not induce fertility, but there are some that you want to avoid, and I need you to know those for sure. I want you to look at page 103. Look at that legal tip. This is where I was going to talk to you about the embryos, how they are now community property and they have to be treated as such in case of a divorce or a death or something. Let's see. So contraception, we talked about spermicides and which ones not to use with condoms, and the reason is because it can cause irritation to the skin that can actually increase the risk for HIV. Let's look at all your legal tips in chapter 5 and your safety alerts. Look at those for sure. Emergency contraception, I need you to realize that that's used within 72 hours of unprotected intercourse. There are different methods available in the United States. Someone I knew had a friend call them and say, I need you to go and buy this Plan B for me, because they were too young to get it by themselves from the pharmacy, but they had already had a pregnancy test come back positive. So she explained to her that's not how that works. That was Plan B. You now need a Plan C. Yes. So abortion, interruption of pregnancy before 20 weeks, either elective or therapeutic. Look at page 121. And one more thing I need you to know. This is the last thing. If you are pregnant, there is one medication that we use in labor and delivery that you do not handle without gloves. And that's another reason we don't share medications. Say you have someone that has ulcers and they're taking misoprostol. It's also called Cytotec. What do we use Cytotec for in labor and delivery? Have you seen it yet? You will see it. We put it in the fornix. We put it up next to the cervix, behind it, around it. We don't put it in the cervix. Oh, heck no. We put it around that fornix there, and it helps to makes induction more favorable. But that is something, the Cytotec is teratogenic, and we don't even handle that without gloves if you're pregnant. Read up on Cytotec. You should probably do a med sheet on that. If I don't know, or have you doing one, we should. So that's all I wanted you to know for chapter 5. So we are done. Thank you for listening. I'll see you next week. Bye.